Cushing syndrome. Hypercortisolism. Introduction. Cushing syndrome, hypercortisolism, is a hormonal disorder caused by prolonged exposure high levels of steroid hormones called glucocorticoids. Exogenous Cushing syndrome, caused by taking excessive amounts of medications, for example prednisone, dexamethasone for chronic asthma, rheumatoid arthritis, lupus, to suppress immune system after transplant to prevent rejection, other inflammatory diseases. Endogenous Cushing syndrome, excess cortisol produced by the adrenal glands. This is far rarer, but if left undiagnosed and untreated it can result in a shorter lifespan. Pathophysiology. Normally, the production and release of cortisol follows a precise chain of events. Corticotropin-releasing hormone, CRH, released from the hypothalamus causes the pituitary gland to secrete ACT, which in turn results in the production of cortisol from the adrenal glands, located just above the kidneys. In healthy people, cortisol begins to rise between 3 and 4 a.m., reaches a peak between 7 and 9 a.m., and then falls for the rest of the day to the lowest levels when the person is unstressed and asleep at midnight. Cortisol controls its own production and release by switching off the hormones CRH and ACT, a form of hormonal regulation known as negative feedback. ACT and cortisol become elevated in response to stress, such as surgery, trauma, infection or other medical illnesses, i.e. stress response. Cortisol performs vital tasks in the body including helping maintain blood pressure and cardiovascular function, reducing the immune system's inflammatory response, balancing the effects of insulin, which breaks down glucose for energy, regulating the metabolism of proteins, carbohydrates, and fats. The problem occurs when the negative feedback system no longer works properly, due to malfunction of ACT/cortisol releasing glands, or there is an artificial excess of cortisol in the body. Causes. Most commonly caused by prolonged use of corticosteroid medications for chronic illnesses such as asthma or rheumatoid arthritis. Pituitary adenomas. Pituitary adenomas cause 70% of endogenous Cushing syndrome cases. Benign tumors of the pituitary gland secrete extra ACT. This form of the syndrome, Cushing's disease, affects women 5 times more often than men. Ectopic ACT syndrome. Ectopic ACT syndrome, benign/cancerous tumors producing ACT outside of the pituitary. Lung tumors cause more than half of these cases, and men are affected 3 times more often than women. Most common forms of ACT-producing tumors, small cell lung cancer, 13% of all lung cancer cases too, and carcinoid tumors, small, slow-growing tumors that arise from hormone-producing cells in various parts of the body. Other less common types of tumors that can produce ACT, thymomas, pancreatic islet cell tumors, and medullary carcinomas of the thyroid. Adrenal tumors. An abnormality of the adrenal glands, usually the presence of a tumor. Adrenal tumors are 4 to 5 times more common in women than men. Average age of onset is about 40 years. Most of these cases involve non-cancerous tumors of adrenal tissue, adrenal adenomas, which release excess cortisol into the blood. Adrenocortical carcinomas, adrenal cancers, are the least common cause of Cushing syndrome. With adrenocortical carcinomas, cancer cells secrete excess levels of several adrenocortical hormones, including cortisol and adrenal androgens. Usually cause very high hormone levels and rapid development of symptoms. Familial Cushing syndrome. Rarely, Cushing syndrome results from an inherited tendency to develop tumors in one or more endocrine glands. E.G. With primary pigmented micronodular adrenal disease, children or young adults develop small cortisol-producing tumors of the adrenal glands. With multiple endocrine neoplasia type 1, men 1, hormone-secreting tumors of the parathyroid glands, pancreas, and pituitary develop. Causes of endogenous Cushing syndrome. Relative frequency. ACTH-producing pituitary adenoma, Cushing's disease. 68%. Ectopic ACTH syndrome, bronchial, thymic, pancreatic, carcinoid tumors. 12%. Ectopic CRH syndrome. Less than 1%. Adrenal adenoma. 10%. Adrenal carcinoma. 8%. Macronodular hyperplasia. Micronodular hyperplasia. 1%. Epidemiology. Cushing syndrome is relatively rare, it affects approximately 10 to 15 of every million people each year. It most commonly affects adults aged 20 to 50. People who are obese and have type 2 diabetes, along with poorly controlled blood glucose, also called blood sugar, and high blood pressure, have an increased risk of developing the disorder. Signs and symptoms most people with Cushing syndrome will have: upper body obesity, above the waist, and thin arms and legs. Round, red, full face, moon face. Slow growth rate in children. Skin changes that are often seen. Acne or skin infections. Purple marks, half-inch or more wide, called striae on the skin of the abdomen, thighs, and breasts. Thin skin with easy bruising. Muscle and bone changes include backache, which occurs with routine activities. Bone pain or tenderness. Collection of fat between the shoulders, buffalo hump. Thinning of the bones, which leads to rib and spine fractures. Weak muscles. Women with Cushing syndrome often have excess hair growth on the face, neck, chest, abdomen, and thighs. Menstrual cycle becomes irregular or stops. Men may have decreased fertility, decreased or no desire for sex, impotence. Other symptoms that may occur with this disease: mental changes, such as depression, anxiety, or changes in behavior. Fatigue. Headache. High blood pressure. Increased thirst and urination. Sometimes other conditions have many of the same signs as Cushing's syndrome, even though people with these disorders do not have abnormally elevated cortisol levels. For example, polycystic ovary syndrome can cause menstrual disturbances, weight gain beginning in adolescence, excess hair growth, and impaired insulin action and diabetes. Metabolic syndrome, a combination of problems that includes excess weight around the waist, high blood pressure, abnormal levels of cholesterol and triglycerides in the blood, and insulin resistance, also mimics the symptoms of Cushing syndrome. Diagnosis. Diagnosis is based on a review of a person's medical history, a physical examination, and laboratory tests. X-rays of the adrenal or pituitary glands can be useful in locating tumors. Tests to diagnose Cushing syndrome. 24-hour urinary free cortisol level. Patient's urine is collected several times over a 24-hour period and tested for cortisol. Levels higher than 50 to 100 micrograms a day for an adult suggest Cushing syndrome. Midnight plasma cortisol and late-night salivary cortisol measurements. The midnight plasma cortisol test also measures cortisol concentrations in the blood. Cortisol production is normally suppressed at night, but in Cushing syndrome, this suppression doesn't occur. If the cortisol level is more than 50 nanomoles per liter, nmol/L, Cushing syndrome is suspected. The test generally requires a 48-hour hospital stay to avoid falsely elevated cortisol levels due to stress. Low-dose dexamethasone suppression test, LDDST. Patient is given a low dose of dexamethasone, a synthetic glucocorticoid, orally every 6 hours for 2 days. Urine is collected before dexamethasone is administered and several times on each day of the test. Cortisol and other glucocorticoids signal the pituitary to release less ACT, so the normal response after taking dexamethasone is a drop in blood and urine cortisol levels. If cortisol levels do not drop, Cushing syndrome is suspected. NB The LDDST may not show a drop in cortisol levels in people with depression, alcoholism, high estrogen levels, acute illness, or stress, falsely indicating Cushing syndrome. On the other hand, drugs such as phenytoin and phenobarbital may cause cortisol levels to drop, falsely indicating that Cushing's is not present in people who actually have the syndrome. For this reason, physicians usually advise their patients to stop taking these drugs at least 1 week before the test. Dexamethasone corticotropin-releasing hormone, CRH, test. Some people have high cortisol levels but do not develop the progressive effects of Cushing syndrome, for example muscle weakness, fractures, thinning of the skin. These people may have pseudo-Cushing syndrome, a condition sometimes found in people who have depression or anxiety disorders, drink excess alcohol, have poorly controlled diabetes, or are severely obese. Pseudo-Cushing's does not have the same long-term effects on health as Cushing syndrome and does not require treatment directed at the endocrine glands. The dexamethasone CRH test rapidly distinguishes pseudo-Cushing's from mild cases of Cushing's. This test combines the LDDST and a CRH stimulation test. In the CRH stimulation test, an injection of CRH causes the pituitary to secrete ACT. Pre-treatment with dexamethasone prevents CRH from causing an increase in cortisol in people with pseudo-Cushing's. Elevations of cortisol during this test suggest Cushing syndrome. Prognosis: if untreated, Cushing syndrome can be life-threatening. If the cause can be treated, whether it means weaning the patient off corticosteroids, or surgically removing a tumor, the patient will fully recover. Complications of untreated Cushing syndrome include diabetes, enlargement of any tumors that are the underlying cause, fractures due to osteoporosis, high blood pressure, kidney stones, serious infections. Treatment: Cushing syndrome caused by corticosteroid use. Slowly decrease the drug dose, if possible, under medical supervision. If you cannot stop taking the medication because of disease, high blood sugar, high cholesterol levels, and bone thinning or osteoporosis should be closely monitored. Cushing syndrome caused by a pituitary tumor or tumor that releases ACT. Surgery to remove the tumor. Radiation after removal of a pituitary tumor in some cases, curative in 50 to 100% of patients with Cushing's disease. You may need hydrocortisone, cortisol, replacement therapy after surgery, and possibly continued throughout your life. Cushing syndrome due to an adrenal tumor or other tumors. Surgery to remove the tumor, followed by radiotherapy/chemotherapy if required. If the tumor cannot be removed, medications to help block the release of cortisol. Prevention. Patients should be weaned off corticosteroid medication for their conditions as soon as possible. Awareness: early detection.